So now we'll have a lunch break, and following the lunch break, we'll have the concluding session, that is a clinical pharmacology in patient care. That session will be post lunch. So now I am requesting all the delegates to take the lunch and then please come back. And those who are having the poster, Professor, one evaluation already done. Now Professor Prabhakar Reddy sir will do the final round of evaluation. So after you take the lunch, then please be ready for that particular evaluation. Thank you. So I request our online participants to finish your lunch too, and you can. We are very sorry that we cannot have that services to send you the lunch box, but after you come, we'll come back after our lunch. Then again we'll have some academic fest.
This is going to be introduced in the next year.
So I think Dr. Bhaskar is not there. So I will request, but it is not good, sir. So we need more physical participation. So I think for that we need to promote physical participation. We cannot provide the lunch online. Thank you once again, madam. Thank you all the respected people who are there. Thank you once again.
Yeah, thank you, Shambhu. Thank you.
So we'll be back at 2:15. So I am requesting all the delegates to please join us at 2:15.
Sir. One more, sir. Thank you.
Request the chairpersons to kindly introduce the next speaker.
Yes. So this is the last session of this 3-day long marathon CME program, and this session is on clinical pharmacology and patient care optimization. There are 4 speakers, and may introduce Dr. Santanu Tripathi, who needs no introduction to our August gathering. He will be speaking on drug-induced disorders, followed by 3 other speakers. That will be again reiterated by our co-chair, Dr. Mukherjee, later on. Thank you so much.
Good afternoon. Welcome to the last session of this conference, 3-day conference. And in this, the theme is, what is the sub-theme of this thing? Drug-induced problems. No, not conference, this session. Patient care, clinical pharmacology and patient care. And there are, I think, 3 or 4 lectures. The first one is this. My talk is actually drug-induced disorders. I consider drug-induced disorder, if you accept this as a disorder, as the name suggests, it's a disease. Now, whenever a patient comes to a doctor, the doctor is supposed to diagnose his disease and then plan the treatment and prescribe. And for diagnosing the disease, there are universally recognized and accepted strategies that you listen to the patient, then you examine depending on the symptomatology. Of course, it is overall examination, but then you focus on particular system, the system that might be otherwise perhaps been primarily involved will get more attention. And then you do the clinical examination, then you do some laboratory investigations, and initially you give a provisional diagnosis. And even for reaching a provisional diagnosis, you also consider a number of differential diagnoses. And then you order some laboratory tests, and as the laboratory test reports come, based on that probably you go for a final diagnosis. That's the way we go. And that's true for any and all diseases. If I am not wrong, We have our internal medicine expert also here, professor of medicine. So, but then any disease you can think of, this is the pathway. And if you accept there is a disease called drug-induced disease, or rather a constellation of diseases, depending on its manifestation, again it could be affecting the central nervous system or GI system or cardiovascular system or whatever. But then as a group, we can call it drug-induced disorders, that also will require diagnosis. And the workup of that patient will not be any different. There also you have to think of, you have to suspect first. And what you are suspecting, in order to cleanse that, or in order to justify whether the suspicion is correct or not, you have to again listen to the patient, take his history, and then again, depending on the symptomatology, we'll go for examination, clinical examination, maybe with a focus to particular system which might be affected most. And then again, in this, through the same strategy, again you have to think of differential diagnosis. It may not be drug-induced. My point is, my stand is, any patient coming up with any problem to any doctor, can he ignore the possibility of a drug-induced disorder as a differential diagnosis? So truly speaking, drug-induced disorder is a common differential diagnosis in all medical consultations. So truly speaking, every doctor is ruling out drug-induced disorder in order to finally reach out any other diagnosis other than drug-induced disorder. And in order to rule out again, he has to go for in a stepwise manner. So it is quite possible, it is very, very unlikely that a doctor coming to a patient coming to a doctor seeking care, at that point of time the patient is not receiving any drug whatsoever. It is quite unlikely. In most of the situations you will find, at least I think, again it depends on the context, the age of the patient, etc. Particularly if you think of an elderly patient, it is almost 99% unlikelihood that the old man is not receiving any drug whatsoever. So if he is already receiving a medication, then you have to also definitely consider whether the medication is actually the culprit for which the patient or this person who has come and consulting me, it is his problems, whatever are the problems, it's not really associated with in any way with this medication that he is taking. But then I have a feeling, I have a belief that perhaps drug-induced disease is an orphan differential diagnosis, if I am permitted to say so. It's not possibly receives the attention it deserves. So it can be a debatable statement, this can be debated upon, but then I actually would like to provoke this debate. What are drug-induced disorders? They refer to conditions or symptoms that are caused or triggered by medications, as simple as that. It can range from very mild side effect to severe and life-threatening reactions. Often a challenge in the context of comorbidities, polypharmacy and complex regimens. The more the number of medications, the more it will be difficult to clench your diagnosis, but the more likelihood it would be that it could be a drug-induced disorder. So it increases exponentially. One drug, 2 drugs, 3 drugs, 4 drugs, as you increase the number, polypharmacy. So the chances of this ultimate diagnosis being drug-induced disorder increases for obvious reasons. Most of us are here are pharmacologists or clinical pharmacologists. Often it is a neglected differential diagnosis. Diagnosis and treatment of drug-induced disorders require a thorough understanding of patient's medical history, medication history, and relevant workup. What I am saying might be very simplistic and very elementary, but many a times the elementary issues also escape our attention. So there is a need for emphasizing and re-emphasizing the elementary issues. Diagnosing a drug-induced disorder, we should learn to suspect. always suspect and rule out. So any patient who comes with any problem, remember, a common DD is differential diagnosis is this, and you have to rule out that and think of other etiologies. History and assessment of the symptom is very important, and for that, look at the patient, talk to the patient, listen to the patient, and identify any symptom that cannot be explained by the existing disease. If the patient you are thinking that the patient has heart failure, can the heart failure be caused by any drug that the patient is using for the last few months or a couple of years? Think about that. Otherwise, it will be, yes, heart failure is diagnosed, but what is the cause behind that heart failure? Or any other this thing, a renal impairment. Okay. Think of whether there could be any medication that the patient is receiving for on a long-term basis could be implicated for this problem. Otherwise, it could be, yes, you are trying to actually, okay, correct the problem that the patient is facing without looking at the trigger factor or the etiology or the causality behind it. Appreciate and understand patient's existing condition and the prescribed medicines, what medicines are already prescribed and the patient is probably complying with. And here is also another area, that adherence issue. On one hand, we say that adherence is always a problem, but at the time when we are trying to look at a pharmacovigilance exercise, an adverse reaction monitoring exercise, there we assume probably that whatever prescription has been made, everybody is very honestly, okay, complying with that. May not be necessarily so. Okay. If compliance is a problem, you have to also think of that problem while we are actually working up on a pharmacovigilance exercise, an ADR monitoring, suspected adverse drug event monitoring. Appreciate and understand patient's condition and prescribe medications, comorbidities and concomitant medications, allergies including drug allergy, etc. And there are many other factors, not only the drugs, there are other factors, lifestyle factors like alcohol, okay, like other things also we have to consider. Examination is definitely a very important part of such workup. Identify any visible signs of already induced disorders. Focused examination of the affected system would be also required. And then if we wish to eliminate or rule out the possibility of drug being implicated or medication being implicated for this, then we need to examine, it is already well accepted steps in an individual case safety monitoring, and there you need to examine temporality, determine the timing of the onset of symptoms in relation to the initiation of the drug. Some drug-induced disorders may develop shortly after starting a medication, while others might take longer to manifest. The ones which are shortly after, it is easier to suspect. The ones which are causing a delayed response, it becomes difficult to really suspect. But you have to keep in mind it is also possible. Lab tests, routine or specialized tests to evaluate the vital organ function on one hand, and then the blood cell counts, etc., and specialized tests like skin patch testing, allergen testing. Some of these have been discussed on the first day. The imaging studies might they also be necessary to make an accurate diagnosis. Yes, we need to try de-challenge. Here lies the question. In fact, why we have kept it here, because as we have stated, it is a relatively neglected area. We are trying to also explore whether clinical pharmacologists, they can be a part of, they can be considered as an important stakeholder in this management of these kind of patients. Any patient who might be suspected to be suffering from a drug-induced problem. So there, when you talk of de-challenge, who can go for de-challenge? Anybody, the person who has prescribed. Here lies another moot question. We often are discussing for the last 3 days and also before that whether a clinical pharmacologist, if we consider him as an expert in this area, can in his own merit and in his own right intervene in a patient whom an internal medicine man is otherwise given a prescription. And if it is done in the best interest of the patient, whether the primary prescriber, how he would take it. These are the moot questions. Most of the time we, the clinical pharmacologists, they feel, how can I change his prescription? Do you ever think of when a prescription written by an internal medicine specialist, he goes to a neurologist, and neurologist, does he think twice to make any change for a neurological problem which has been otherwise treated by an internal medicine consultant, or for that matter a cardiologist? So why is it we are thinking, why we are so not having enough confidence that this is our area, critical skill area, a adverse drug-drug interaction problem. If it is very clear in front of our eyes, why can we not make a comment? If we feel very shy about it, at least we will write a comment and request the patient to go and to his primary prescriber and show this. So trying de-challenge is again an issue, okay, which can stimulate debate. Who is going to do the de-challenge? Otherwise, in pharmacovigilance exercise, we have always said that the pharmacovigilance officer or pharmacovigilance personnel is not supposed to do de-challenge. If de-challenge is done by the primary physician, what is the implication of that de-challenge? What is the outcome of this de-challenge? The pharmacovigilance personnel will follow that. That means pharmacovigilance expert or pharmacovigilance professional, he is rather a passive kind of person who will look at the outcome and try to deduce rather than doing any active intervention. But here what we are discussing, I would be rather expecting a trained clinical pharmacologist will have the confidence and courage to do the de-challenge, provided he is convinced if I don't do the de-challenge and ask the patient to go to the primary prescriber, the delay in this is going to otherwise cause damage to the patient. And primarily we are doctors. Ethically also we are not supposed to do this. If we feel this is not going to be in the best interest of the patient, we definitely have the authority to do de-challenge and also mention there why you have done that. I agree that we also have a professional, okay, obligation, co-professional respect, but at the same time, if we can prove your point that in the best interest of the patient it has been done, and this is by no way, okay, to show any disrespect to the primary prescriber, I think there should not be much of a problem. This is unnecessarily we are taking this a little too personal into this. So trying de-challenge and re-challenge, seeing if the symptoms improve with temporary discontinuation of the suspect medicine and then reappear if at all it is ethically possible. Many a times re-challenge might not be acceptable again in the interest of the patient. But in certain situations like in TB management, etc., there re-challenge is often done, particularly when you talk of the hepatotoxicity issues of most of the anti-TB agents. Pharmacological plausibility is again another area where a clinical pharmacologist has a greater strength and can check if the suspect drug is already known to cause the same problem. So that again goes in favor of the causality. Alternative etiology again has to be ruled out if we want to establish that it is because of the drug. Pharmacological plausibility and alternative etiology means consider if the problem can be explained by the existing disease or any other risk factors. So that is a negative attribute, and if it is actually explained by existing disease, then the possibility of drug-induced becomes less. And finally, as a clinical pharmacologist, we have an additional obligation. Of course, we are expecting that any physician will do that, but in reality, most of the time that is not happening. But if you are a clinical pharmacologist and trying to also serve your patient through clinical pharmacological consultation, reporting to the appropriate authority, in this case a pharmacovigilance program, that also becomes our obligation. So, treatment, coming to the treatment of the drug-induced disorder, once we have diagnosed, now can we treat? My question is, my argument is, why not? so long it is within your knowledge domain, within your comfort zone. If it is otherwise has affected the heart, or if it has affected the kidney or the GI system or the liver, and if you feel that it has to be a consultation or referral to a hepatologist or a cardiologist should be done, do that. But that doesn't mean that you cannot treat. Okay, you can refer the patient to this thing. This is drug induced, that much I have done, that diagnosis I have done. But for the rest of the treatment, I am referring the patient to the cardiologist or the neurologist or whosoever, depending on what is the manifestation. So consider if the drug requires tapering to prevent withdrawal or rebound effects. So this is again whether it will have the withdrawal rebound effects and how the tapering should be done. Here also the clinical pharmacological expertise and wisdom would be otherwise, I suppose, welcome by our clinical colleagues, other clinical colleagues. Symptom management is also a part of this treatment regimen, and depending on the severity and nature of the drug-induced disorder, symptom management could involve medications to alleviate pain or inflammation or allergy or any other symptom. Supportive care is also important could be crucial for some drug-induced disorders, involving measures like rest, hydration, monitoring vital signs. And for all these, of course, we have discussed also that if necessary, if there are some tweaking in the curriculum is to be made, it has to be made. If we feel with the given kind of training, we are not very confident to also provide this clinical care because of our deficiency in our current training program, we have to change that. We have to do that. But then this, hopefully, if we feel that we are enough trained, we should be able to do this. Substitution of the medication. If one medication is causing this, whether you are substituting with another medication of the same group or if you are going to the other group, and whether by substituting the medicine, you can really avoid the primary problem, the drug-induced problem, that also a clinical pharmacologist is a better person to suggest that. And clinical pharmacologist can provide that advisory or consultative service or referrals, consultation or referral advice to his clinical colleague, or he can just do that in the prescription. So discontinuation of the offending drug is not possible due to essential treatment. Consider substituting the medication with a safer alternative. And the last one is important. So follow-up is essential whenever you are managing such a patient, monitoring, close monitoring. After discontinuation of the offending drug, monitor the patient's progress closely, follow-up appointments and additional tests may be necessary to ensure that the symptoms are improving and to address any lingering effects. And secondly, of course, what is this follow-on, follow-up, monitoring and then follow-on. By follow-on, I wanted to mean that also give a report or give a kind of card to the patient, particularly in case of allergy. Mention that and ask the patient whenever he visits any other doctor, he should carry this card. If he is really allergic to a particular drug and you have identified that, so that should be given to the patient. Okay? Or if even if it is not allergy, even if there is a adverse drug-drug interaction, you can mention that this patient has shown already this. So if he carries a card and that card next time when he visits his cardiologist or his neurologist, he also shows that card along with other prescriptions. So that can also help him, that can also act as an alarm or an alert to the next prescriber who will possibly take a little more caution, exercise a little more caution. So management of drug-induced disorder should be individualized based on specific circumstances of each patient. It's important to consult a qualified clinical pharmacologist or an informed pharmacologist. I give emphasis on this adjective, informed pharmacologist. Not necessarily always we have to be a clinical pharmacologist probably, because truly speaking we do not have enough clinical pharmacologists in the country. Altogether we might be having 120 plus, while if we try to champion this concept or this strategy, again it can boomerang that you are telling all this, but where are the people? Okay, they are not visible. How many clinical pharmacologists are there? But what we want is not necessarily a trained clinical pharmacologist has to do all by himself. He can train pharmacologists, he can train even pharmacists. But then again you have to supervise. The pharmacists they are not authorized to do prescribing. So you can have a team of pharmacists, clinical pharmacists who can help you, support you, okay, provide the necessary assistance, and then you get into prescribing business. It's important to consult a qualified clinical pharmacologist or an informed pharmacologist for proper diagnosis and treatment. And if you suspect you are experiencing this, actually is addressed to the patient. There was also question whether a clinical pharmacologist, when he is acting as a consultant clinical pharmacologist, he will only expect referred patients to him, or he can also expect directly patient will come. Today it may appear that directly patient will be coming to a clinical pharmacologist. So, but then hopefully in coming years, if we can position ourselves properly, if we do promote it, if we project ourselves properly, publicize it, why not? Educated patients, if they suspect it could be because of drug, directly they will come to the clinical pharmacologist. That's my dream. I feel that in near future, maybe 5 or 7 years or 10 years from now, there will be people directly coming to a clinical pharmacologist seeking consultation. Is it because of any problem with my drugs? Thank you very much. Iatrogenic illness, that was the last one. And this is how to approach. There are some this thing. This is also the same way. Like if we call them iatrogenic, then also this part also has been missed out. That clinical pharmacologist can actually do that, preventing further this thing. How can you prevent iatrogenic disease or drug-induced disease? For that, the kind of awareness recognition that is to be done, communication, reporting, and learning from errors. Medication error is another area, which again is in the domain of clinical pharmacologist, and multidisciplinary approach is to be emphasized, individualized care is to be emphasized, risk-benefit assessment is a domain of clinical pharmacologist, regular monitoring, patient empowerment, and continuous education. That's it. Overall, a proactive and patient-centered approach to healthcare combined with a commitment to safety and continuous improvement is essential for preventing and managing iatrogenic diseases or drug-induced disorders effectively. Thank you very much.
Thank you, sir. Thank you for enlightening us about a very important and indispensable topic, that is drug-induced disorder. At this juncture, I would like to thank Dr. Sambhu, the organizing secretary of this mega conference, and organizing chairperson, Dr. Santanu Tripathi. My heartfelt gratitude and thanks for allowing me to chair this session. I have a medical board. I am attached to this hospital, so I have to leave by 2:40. I take the permission of my co-chair, so I will be there for another 10-15 minutes. I hand over.
Before you leave, we need your opinion.
Okay. Okay. Okay.
How do you like this? What we are saying
And,
that a clinical pharmacologist.
I absolutely agree with you, sir, because sometimes we are actually in a dilemma and we need support from a person who is expertise in this field. And there is no denying the fact that internal medicine people are concerned with so many things, but we are actually incomplete without help of other subspecialties, super specialties. And in this particular topic, this drug-induced disorder, what you have said, I fully agree, and like me, I think that everyone who is here will fully agree that a day will come that the patient or the individual will come directly to the pharmacologist, clinical pharmacologist, and there is no shame on the part of the internal medicine, because that will actually, our goal is unified, the goal is same, to improve the quality of patient's life.
And the point I just want to mention about the medico-legal part.
Yes, sir. That, yes. Right.
You get an opinion of
Yes.
clinical pharmacologist.
Yes.
Okay, you can
Yes.
say that I had, but ultimate liberty of yours.
Yes.
Okay. You
This is very important.
get referral opinion from neurologist.
Yes,
Finally,
yes.
the patient is yours.
Yes. Responsibility is,
yours.
yes.
To what extent you will be accepting their advice, that is your choice.
Yes, sir.
But if you send your patient to a clinical pharmacologist, you are guarded. In the court, you can say, I
Yes.
have taken opinion.
100%, because,
I have done this. So you are guarded.
yes, and particularly this is important in view of de-challenge and re-challenge. That is the most important part we face in day-to-day practice, that when to actually, how to counsel the patient, and when we get support from our own colleagues, particularly the clinical pharmacologist, or sometimes we get the help of microbiologist in case of infections. So that boosts up the morale of the patient also, as well as the physician. That is what is important. Thank you, sir. I hand over the mic to our co-chair.
Thank you. I actually, much appreciated this last presentation, particularly the approach of looking at drug-induced disease from the point of view of a disease. And you have to follow the same procedure as you would do for any other disease. Now, in a clinical pharmacology consultation, I think that is no longer a differential diagnosis. When the patient has come to you for a clinical pharmacology consultation, then we are taking it for granted that that person is a complex therapeutic, in a complex therapeutic situation. He has got multiple diseases. He probably is a subject of polypharmacy and whatever other conditions he might have, a drug-induced condition. Yes. Exactly. A drug-induced condition is quite likely. So I think when clinical pharmacology consultation is happening, that needs to be the first focus to rule that out first of all. And then maybe we can think of any other things, but quite right. So thank you so much, Dr. Tripathi. We come to the next presentation, which is by Dr. Santanu Munshi, addressing adherence in chronic patient care. Professor Munshi is, I understand, heading the Department of Clinical Pharmacology at School of Tropical Medicine. Please take the dais, Professor Munshi, and we look forward to your presentation.
Thank you so much, Dr. Shoibal Mukherjee. It's a privilege for me to present immediately after my teacher, Professor Tripathi, who is a doyen of clinical pharmacology, and it's a really challenging moment for me. Okay. We all know this issue of medication adherence, and it's so very important, and we, the clinician, they face a lot of challenge because of this issue, and it contributes to a great extent to increasing the healthcare cost, not only increasing the healthcare cost, and it reduces the quality of life of the patients. It can also bring about a lot of health issues as well as treatment failures. And in Western world, if you see every 100 prescriptions, only 25 to 30 prescriptions are followed properly. So there lies the challenge. So it's a very common day-to-day problem we need to understand as a pharmacologist and clinical pharmacologist. And fortunately nowadays we have a lot of tools, and if we can use those tools, and there are a lot of softwares also, software-based applications, and if we use them, it helps in treating this problem, reducing this problem of non-adherence and converting them to adherence. There are several factors for non-adherence, and we need to understand these barriers to adherence, like cost of the medications, like incomplete patient education, like limited health literacy for the patient, as well as forgetfulness, because elderly patients, they have cognitive challenges. So those issues have to be identified, and individually they have to be dealt with. And there lies the role of the clinical pharmacologist to get into that and identify it and solve this issue. So what should be the correct approach? Approach should be that not to go into it in a general way, rather based on the barriers. Try to find the specific barriers which are happening for that patient and individualize your approach and thereby you can overcome this non-adherence issue. Now coming to a case, if we discuss this patient case, it will be very easy. Mr. Avery is a 62-year-old man who has elevated blood sugar since the age 40. He has been encouraged to maintain a healthy weight and decrease carbohydrate sugar intake. However, during his last clinician's appointment, his A1C was 9. So there has been bit of discrepancy about what the patient is saying and what the results are showing up. So definitely, if you see the medication chart, that you find that there is poor compliance. He has arrived for his first appointment with you, and how do you accomplish in this session? So what we need to ask to understand that what are the behaviors do you want to address? The patient's behavior to medications, and whether they are modifiable factors that may be impacting patient behavior, and whether the health behavior strategy, which particular strategy you want to apply for this case. Now, to understand this situation, that patient is of diabetic patient is not only suffering from elevated blood sugar, but he also has host of other problems like hypertension, lack of activity, raised BMI, and the patient is a smoker. Associated to that, he is suffering from depression, and there are psychosocial stress which are also involving. And all these factors may, lead to heart disease, cardiovascular problems. So where do we start and how do we start? That's the question. So WHO defines adherence as extent to which person's behavior, taking medication, following a diet, making a healthy lifestyle challenges correspond with a agreed upon recommendation from the healthcare provider. And our Agency for Healthcare Research and Quality defines medication adherence. More specifically, it says that the patient's conformation or conformance with the provider's recommendation in respect to timing, dosage, frequency of medication taking during the prescribed length of time. So this is a more comprehensive kind of definition. And basically we need to understand that drugs don't work in patients who don't take them. So adherence is so very important, and you have to ensure that for every patient to get the outcome, desired outcome. So if we go into this medication adherence statistics, you'll find there is very interesting, approximately what is the percentage of prescription which are never picked up from the pharmacy? Any idea? 20 to 30% of the prescriptions are not picked up from the pharmacy. And this is the Western data. This is the Western data, US data. 50% of the medication for chronic disease are not taken as prescribed. An estimated 10% of the hospitalization in older adults are caused due to medication non-adherence. And over 300 billion avoidable healthcare cost has been attributed to non-adherence in US annually. There are several studies, and it has of 1,705 patients with diabetes and hyperlipidemia, and showed that the adherence has decreased the all-cause medical cost by 15%. So there lies the importance of implementing medication adherence and how to go about it. is our challenge. The problem of non-adherence, there is clinical outcome related problems like it causes poor therapeutic outcome, can progress, the disease can progress further, and also the quality of life will be decreased. And there are economic outcomes also. There will be increased cost to the healthcare system, increased amount of hospitalization, and also the frequency of emergency department visits will increase and physicians' visits. There will be loss of productivity also. So what are the reasons for common reasons for non-adherence? The first is, we know the common one is the patient complains about the side effects, concern about side effects. Next we have another is there any efficacy to be expected if I take these medications? So there is a doubt in the patient's mind regarding the efficacy, or whether their need is there, actual need for treatment is there. Next is your cost. If the cost is high, automatically the adherence will be an issue. So we need to understand the patient's ability to procure the drugs and consume them effectively. And forgetfulness is, yes, that's another common issue for non-adherence. And we need to tackle all this along with lack of support, social support, impaired cognition, low health medication literacy, as well as if the patient does not able to follow the instructions. So there is need for better physician versus patient's interaction. And sometimes, the patient pill burden is so complex, you giving 4 to 6 times daily, and in the middle of the night some tablets have to be taken. So those are real challenges. Also, as a physician, as a pharmacologist, we can look into this adherence problem from outside, and we can predict how much the treatment will be adherent to by looking into the organizational context, like whether the patient is under insurance so that the cost will not be a limiting factor, or whether the patient has, this individual problems of the patients. And we have this social support is also very important to provide backup or reminder kind of things, whether the patient is taking the medication properly. And sometimes patients require some sort of encouragement from their family members, and who call them up and inquire whether the medications have been taken properly or not, because these are chronic disease and they have to continue their treatment for a pretty long time. So that is important. And we should also understand the patient's belief, attitudes and personality before prescribing them the drugs, so that will also predict the adherence. So what is the strategy for this assessment? We have certain tools. We need to understand this self-report of the patients, and also we have these apps and other devices which will tell us whether the patient have been regular with their medicines or not. And very important, lab values will also reflect whether there has been compliance to the treatment or not. And so how do we ask the patient about adherence? Patients, most people forget sometimes, but how often do you forget to take your medicines? So that we are giving that, being a human, we can make an error, and it is not very out of the box to be forget taking medicines, but how many times you are forgetting, and if you feel better, are you stopping to take the medicine, or if you are feeling worse, do you sometimes stop taking your medicines? These questions will, give you the feedback whether the patient is adherent or not. And self-monitoring, you have this medication log sheet where individual drugs, name of the drugs are mentioned 1, 2, 3, 4, and how many times they are supposed to take, and if they are stopping, what is the reason, and all these things. If any side effect, they write it down, and you get a feedback from that also. Along with that, if you see this, there is this apps are given. These apps are usually available there also. We have our Indian apps which are very useful, and if you can use it, it will be very useful. They are very useful. And we must also look into the objective data, that like exactly after the treatment, suppose you are giving drug for reducing blood pressure, if you check the BP, whether the BP has been under control or not, whether the sugar has come down or not, or whether the body weight is controlled or not. Along with, you have these apps which give you objective recordings. So, how do we confront the patient? The patient was telling that he has been trying to maintain a good diet and a good exercise plan, and has been compliant with the medications. But the patient now admits that he has been watching his diet and monitoring his blood glucose, more vegetable, fewer desserts. I have been making a lot of changes, but my blood sugar, it's been below 150 for most of the time. But the results of A1C tells that it is 8, which indicates poor control. And he has also left his glucometer at home. That is conflicting. And so you now have to review the data, and what do you do, what do you believe, and you have to confront him with this conflicting data. And later on he confesses that, okay, maybe I have been taking I haven't been taking my medications as I should have, and I've been eating too much of ice creams in the evening. And he comes with this confession, and then you have to handle that as well. So these are the very interesting situations, and this is how you approach in a patient who are less adherent. And there are evidence-based approaches where 5 main points are: you have to educate your patients when you're prescribing these chronic medications, and the importance of this medication, the benefits, and what is to expect during the treatment, whether there is some common adverse effects, whether they check, how they monitor. Because after all, these are patient-oriented. They have to take responsibility. You have to motivate the patients. Okay. Another is there are specific barriers, and you have to identify with the barriers and give specific management for that. And you have to help the patient take medicine as a habit, and it is better if the patient takes during the breakfast time, during the morning period, and along with a common routine during breakfast, before breakfast, or where after brushing your teeth, things like that. That is how they will, adhere to that treatment. And motivational interview where, you engage the patient in a talk and give a positive affirmations, and try to plan out a change in behavior and implement that. and that is very challenging. And what you intend to say is that if you follow this, will it be good for you or will it be bad for you? And if you don't follow this treatment, whether that is going to be good or bad. And this is the decision balance the patient needs to understand, and this will help in changing their behavior. And there might be specific barriers to adherence. Others are there, like some patients are phobic. They do not want this insulin pricks. So then you have to tell them that what is the benefit and how to go about it if they don't take their insulin regularly. So there lies the challenge. So those behavioral change issues has to be dealt with, and somebody has to help there also.
Professor Munshi, how many slides do you have?
I have two more.
Can you just, I'll just ask your permission. My co-chair has to leave for a very urgent meeting. We want to felicitate him before he goes, and then we'll continue with your presentation. Already felicitated? Okay. Yeah, you've got it. So thank you so much for being here and being my co-chair.
Thank you, sir.
Professor Munshi, you can please continue.
Yeah. Yeah. So we have to address the specific barriers, and like if the patient has phobias to needles or to taking pills, and how to overcome them, and how to help reminders, set reminders so that they do not forget to take the medicines in time. And there are several smartphone applications which are available. We can easily download and use them. And they have been designed for various kind of treatments, and they give you notifications, and also they have time zone arrangement. If you are traveling, it can be taken care of, all those time zones. And even the family members are also alerted if you forget one or two doses. So another important thing is self-management training, where the patient is rewarded if he does the things properly, and if he doesn't do properly, then he has to be again taken up and dealt with accordingly, giving him the advices and behavioral changes, looking at the barriers, specific barriers. So what is essentially meant here, that you require reinforcement to improve the behavior and improve the adherence, medication adherence. So I just mentioned that it's a better idea that you try to take the medications along with the existing habit, like when with breakfast or brushing your teeth, AM, PM, or before going to bed. That will help you remember the exact timing of the medications. And it is a good idea that if you forget to take the medicine suppose at home, you carry your medication in the purse. Whenever you remember, you take it, and even you can keep it in the car for a momentary period, limited period, because there is again the medicines are temperature sensitive, and they might get spoiled after a certain period of time. And always try to encourage the social support, like friends and family, to remind the patients about the medications. And it's a good idea to connect adherence to values and meanings, invite patient to reflect upon why do you want to improve how to take your medicines. And how will improving your use of medicine impact your life? If the patient understands this will improve their behavior regarding the medications and their adherence to medications. So there is something called patient brochure where we have all these things written down, and every institution should have them, and they can be shared, especially with chronic medication usage patients. And we can also take help of this pill box and other organizers, pill organizers, alums like this, that will also help in overcoming the non-adherence barriers. There is something else known as this electronic health record template, where we can also implement this adherence portion, that the patient is using a pill box, or whether a patient is using or not a pill box, or the patient is taking how many times a day, frequency of the missed dose of any medications per week, like that, and what are the common barriers he or she is facing regarding this adherence, and how to improve this adherence, whether the help of family and others are required or not. And accordingly, we can also plan our intervention and follow it up so that the patient is benefited with a proper health outcome as desired by his physician. So there is something also known as, after the patient leaves the consultation, after visit summary template, where the patient came for this and we talked about this, and these are the areas where we suggested some help is required, and how to go about it, so that next visit this can be monitored, and these areas, how it has improved, we can look into it. So this is all the structured practice, and we practice these activities, and sometimes we can do a role play also. The one patient becomes the patient, one person becomes the patient, other the provider or the doctor, and they play among themselves how to take the medicine, how to improve, what are the challenges they are facing, the barriers they are facing in following the instructions, and how to go about it. And this will be observed by other real patients, and they will understand what are the issues and how to improve medication adherence. So these are the issues where the patient, doctors face, that I hate taking pills, and it seems every time I come to the doctor I get more pills. These are the common situations where the doctors face these questions, and doctor has to re-emphasize, refocus that the medicines are important, and how to go about to reduce the pill burden, how to patient understand that these are very important for his treatment. And also the issue of I feel worse than before when I started. So there lies the indication that some side effect have occurred, and the patient doesn't want to continue the treatment. So the doctor needs to understand how that has happened and how to go about it. So this is more in a small talk about this adherence, and there are certain more resources which are available online. We can always go and look into it. Thank you. Thank you so much.
Thank you, Professor Munshi. It was really quite exhaustive, and the various ways that are used to encourage adherence to therapy are very interesting to look at. I only wonder whether some of this is possible to do in the Indian setting, where you have so many patients coming in, and you have to quickly the turnover of patients is so high. Nevertheless, I like the idea of having a kind of checklist at the patient's visit, particularly for chronically ill patients, to ensure that they are actually taking the medicine, and check it out all the things that can be done in case it seems that they are not taking the medicine as prescribed. Thank you so much. Are there any questions that anybody would like to address? Dr. Munshi? Well, if there are no other questions, Professor Munshi, thank you so much for this presentation. We have to go on to the second last presentation of this conference. Is that right? And this is by Dr. Chiranjib Bagchi. Will he be online? Dr. Bagchi is here. Yeah, here he is. So welcome Dr. Bagchi to the dais, and his topic is safe prescribing in hepatic compromised patients. Stage is yours.
So, thank you, sir. I express my sincere thanks to the organizers, especially my teacher, Professor Santanu Tripathi and Dr. Shambhu Samazdar, for giving me this opportunity to speak on this issue. In fact, this hepatic, these hepatic disorders, in fact, the safe prescribing in hepatic disorders, that's a very important issue. In fact, we know the, why should I know about this? Because many of the drugs, actually, what we use, most of the, more than 50% of the drugs used in the common practice, they are getting metabolized in liver. In fact, either they are metabolized by different enzymes or the liver transport all these drugs. So naturally, we need to look after this organ function most diligently. In fact, due to this derangement of this liver or this hepatic function, this doesn't already actually intend to have an effect on this desired effect also, but that may lead to the occurrence of some adverse drug reactions, and that's why we need to properly, judiciously select the drug as well as to adjust the dosage of the drug. So what are the considerations? In fact, there are different considerations we need to file. We need to handle these drugs in this particular group of patients, like increased hepatic clearance of the drugs, as the in fact the hepatic tissue which deal with these drugs and hepatic function that is compromised. In fact, the reduction, there is a reduction of the hepatic blood flow because of these other comorbidities, like the patient if is in shock, or the patient is in critically ill, so naturally heart failure, so there is also decrease in hepatic blood flow, and that has also have an added value. Actually, that parameter is to be considered while treating these patients or adjusting the dosage of this particular drug in this particular group of patients. In fact, decreased plasma protein concentration is a parameter that often happens in case of the patients with the deranged hepatic function. So as you know, the hepatic disease patients, there is decreased production of albumin. So naturally, the free drug level becomes often elevated in the system. And the reduction of the number of the active and functional hepatocytes, decreased first pass metabolism, what is the most important factor which is involved in the drug metabolism, especially in case of the drugs with high extraction ratio. And naturally, when this first pass metabolism is deranged, so naturally that leads to the increased bioavailability of the drugs. So these concepts and these considerations should also be taken care of while treating the patients, and of course the selection and dose adjustment in this particular group of patients. And impaired renal function, that is also another issue. And we know this hepatorenal syndrome happens in case of the advanced liver disease. And so in addition to take care of this liver issue, we need to consider this renal function, decreasing renal function while adjusting the dosage in this particular group of patients. And we all know that there is a very simple equation to identify or to calculate the clearance of the hepatic clearance of a drug. What is hepatic clearance? That is spatially, that is the intrinsic hepatic clearance. That means that hepatic metabolizing capacity or hepatic transport capacity of different drugs in this particular patient, and that can be derived with a simple equation, that is by multiplying with the hepatic blood flow, that is QH, with the extraction ratio, that is EH. And this extraction ratio is also, it differs from drug to drug. Some drugs are having high extraction ratio, some drugs are having low extraction ratio. But the problem is that this kind of equations are they look very simple, and that is very much good in modeling this drug designing and drug development and phase 1 studies, but is very difficult to apply in exact clinical practice. Clinically, when a clinician treats a patient, there is hardly any scope to apply this formula to adjust the dosage of this particular group of drugs. And that's why their clinician should consider the other parameters like hemodynamics, alteration of the hemodynamics and other inherent intrinsic clearance of this particular group of drugs and the quality of the drugs, that is whether these drugs fall in the group of the high extraction groups or the low extraction groups, and quality of the protein binding in this particular group of drugs, that factor should be considered. And also along with that, the shunting of the blood, that is also an important factor which happens in most of the cases of the advanced liver disease. Intrahepatic shunting of the blood, you all know there is portal circulation is happening there. So that also affects the disposition of the high extraction drugs into the liver, and in fact the excretion of the bile acids, that is also is an important parameter, is recognized as an important parameter for calculation of this hepatic shunting procedure. So that can also be used as a parameter in some occasions, if at all it is to be used, because these the hepatic perfusion and the intrinsic clearance, that is unpredictable in any way. That differs from person to person. So there should not be there is not any clear-cut equation by which you can delve into the exact drug dosing in this particular group of patients, like these renal disorders, where we have the cockroach ball formula or MDRD formula and so. So, and in fact, the impairment of the drug metabolism is proportional to the liver dysfunction. So, in a compromised hepatic function, that is where then there is a decompensated hepatic failure, in that case naturally the drug metabolism is more hampered, more deranged in comparison to this to the patients where there is a compensated, with a compensated state of hepatic function with cirrhosis. So naturally, the way of treatment in this between these two group of patients differ. And now these pharmacokinetic dose adjustments, how it is being done usually by applying several tests, that is commonly starting from this liver function test, the Child-Pugh score, the MELD score. Often this MELD score is used before the hepatic transplantation. Child-Pugh score is a very common score, but we all know that is all these scores and tests are not very accurate. In some cases we can apply these scores and these tests. And in fact, in case of the drugs having the high first-pass metabolism, you need to reduce the dose, because there is actually to reduce the oral bioavailability of this particular group of drugs. And because as the first-pass metabolism is hampered in this particular group of drugs. For it is now there is a dictum that is in high clearance drugs you need to adjust both the loading dose and the maintenance dose, but in case of the low clearance drugs you need to adjust only the maintenance dose, as the mechanism as I have explained the mechanism, because in the high clearance drugs you need to take care of this hepatic intrinsic clearance also, and in fact in the low clearance as you only need to adjust the maintenance dose. So therapeutic drug level monitoring is also the monitoring of adverse effects of the is also key, that should always be done, because that is one very good tool to adjust the dosage, in particularly in case of the low clearance drugs, low extraction ratios. I will come to this point later on. So now this is the Child-Pugh score. It has been published by the US FDA and European Medicines Agency, and that has been integrated into the drug trials or different phases of drug trials, they apply this code. And this code is actually, this encompasses different parameters, clinical and biochemical parameters, starting from the encephalopathy, ascites, bilirubin, albumin, prothrombin time, INR ratio, and according to that, they have segregated the patients of the hepatic dysfunction into several categories, starting from child class A, child class B, child class C. Child class A is a less severe hepatic liver disease, child class B moderately severe liver disease, and child class C is the most severe liver disease. So now what happens in case of the high extraction drugs, as it is mentioned, that is well accepted, that is these drugs having the high hepatic extraction ratio. So naturally, as these drugs, the oral viability is very less, and this has got a high first pass metabolism. So what happens in case of, if this is deranged, this hepatic function is deranged, naturally there is every chance the oral viability will increase, and so as the first pass metabolism is affected. So in that case you need to reduce the dose. How you will reduce the dose? You will reduce the dose applying this formula, that is normal dose into bioavailability divided by 100. So in case of this high extraction drug, that is very important is that the hepatic blood flow has got a very good, important connotation, has a very important impact here in this case of the high extraction ratio drugs. And in that case, you need to, the clinician need to consider the inherent hepatic blood flow in this particular group of patients. That is the comorbidities, that is the heart failure, that is the shock, that is the other critical illness where the hepatic blood flow is compromised. If the hepatic blood flow is compromised, naturally that will add on to the hepatic dysfunction, and naturally you need to further reduce the dose in addition to this factor applicable for the bioavailability. So these are the examples of different drugs which have this property of high extraction ratio. And the low extraction ratio drugs, more than 70% oral viability, as because the intrinsic clearance impact is less here. So these drugs are having the high, more oral bioavailability. So how can you adjust the dosage here? Here you can apply the Child-Pugh score. So if the patients are having the less severe hepatic disease, you need to adjust the dose in 50% of the normal maintenance dose. In case of the child class B, you need to adjust the dose in the form of 20% of the normal dose, and in case of child class C, you better to avoid this dose which has got a very, for the drugs which are not at all safe for the hepatic compromised patients. And in fact, you need to consider here also the protein binding capacity, because in case of the low extraction ratio drugs, the protein binding capacity of the drug and the intrinsic ability of the drug, that is intrinsic inherent disease of the hepatic disease of the particular patient, has a great bearing on this particular group of drugs. So that's why in addition to this dose adjustment, according to the inherent disease of these patients, you need to consider the protein binding here as well. I have mentioned that in case of HED, you need to consider the hepatic blood flow additionally. Here you need to consider the protein binding additionally. So in case of the protein binding, you know this, there are some drugs which has got high protein binding. There are also some drugs which has got low protein binding. So in case of naturally the patient, the drugs having low protein binding, the chance of the free drug level is more, and naturally you need here, the only solution is that you need to measure the free drug level through the TDM. So TDM is very important here in the low extraction drugs. There are some drugs which have got intermediate extraction property, and this between the 30 to 70% oral bioavailability, and the dictum here is the start low, and for the maintenance you need to calculate as per the LED drugs. As because these drugs are having the both type of qualities like HED and LED, so here the dictum is like that, and the ciprofloxacin, carvedilol, midazolam, omeprazole, these groups of the drugs fall into these groups. Now comes to the pharmacodynamics, how it is being altered. I have talked about pharmacokinetics and now pharmacodynamics. There are different responses, altered responses, pharmacodynamic responses here in this case of hepatic compromised patients. One is the increased susceptibility of the patient to hepatotoxic reactions or other adverse effects, and the drugs are implicated in this being is that this acetaminophen, AC inhibitors, aminoglycosides, they are having increased susceptibility to have some adverse drug reactions or hepatotoxic reactions. Another important factor is that blunted response to the diuretics and vasoconstrictor in this particular group of patients having portal hypertension, because you see that in this case there is the furosemide, the response of furosemide is often blunted. That's why the torsemide is preferred here. Because as in ascitic fluid, from the ascitic fluid, actually the sodium excretion rate is, it has been studied, that is very low in case of these patients with ascites with furosemide. So it's now the furosemide is a very well recognized drug that is often used in case of the hepatic compromised patients for increased diuresis and these things. And so you need to escalate the dose up to a ceiling effect. And in that case, it is being often stated that the torsemide is better than the furosemide in this regard. And of course, in case of the vasoconstrictors, you need to consider and monitor the patients because there is because of the blunted response of the vasoconstrictor. So there might reduced response to the vasoconstrictors, particularly in this group of patients, and that's why the physicians need to look after this fact very, very judiciously. Now, the adverse drug reaction in the liver disease, actually liver disease patients, they tackle the adverse drug reactions very poorly. And that's why some group of drugs there is no to use these drugs, like these antitubercular drugs, aminoglycosides, NSAIDs, beta-lactam antibiotics. These group of drugs are often come as a hazardous in this particular group of patients. And the poor nutritional status, renal dysfunction, concomitant drugs, they add values to these deleterious effects. And in fact, some drug-drug interactions should be taken care of. There is alcohol with paracetamol. Alcohol promotes the metabolism of paracetamol and to produce a toxic metabolite. Alcohol increases the gastrointestinal bleeding chance when it is used along with NSAIDs. Alcohol increases the chance of hepatic encephalopathy when benzodiazepines are used along with these. So these types of drug-in-drug interactions should be kept in mind. And next is the antibiotics, because the antibiotics are very frequently used that are needed in case of the hepatic compromised patients. Why? Because the hepatic compromised patients suffer from the lack of immunity and they are susceptible to infections, and that's why these patients are often need more and more antibiotics. But you see that there are many antibiotics which are to be avoided here in this particular group of patients, like erythromycin, azithromycin, tetracycline, chloramphenicol, griseofulvins are all contraindicated. And ATD, there is an important, because some of the patients, they need ATD. In case of suppose a patient is suffering from tuberculosis as well as the patient is having the hepatic compromised state, and so won't you treat the patient? So there is a dictum or there is a guideline how to treat this type of patients. If the cirrhotic patient has got a compensated hepatic function, you can use these 4 drug ATDs. But you should monitor the patients, okay? But the decompensated patients, they poorly tolerate the hepatotoxic drugs. And that's why in case of the child A category of the patients, recommended ATTs can be used, but the patient should be monitored very frequently. And in child case B patients, that is the moderate compromised hepatic function, then one or another hepatotoxic drugs can be withdrawn, like this pyrazinamide should be avoided. Isoniazid should not be used along with rifampicin, either isoniazid or rifampicin plus ethambutol plus any of the quinolones, that should be used for 12 to 18 months. And in case of the child class C, is a severe grade of disease, you should not use at all any hepatotoxic agents. You should use either this combination of this ethambutol plus quinolone plus any second line agent like bedaquiline, maybe delamanid, like this for the 12 to 18 months. So regarding the other drugs, that is for the short procedures like endoscopy, then other bronchoscopy, there is procedures. Usually we use midazolam there, but midazolam is contraindicated in decompensated cirrhotic patients. Propofol is a better choice because it is safe and it has a less propensity to induce hepatic encephalopathy. And regarding the anesthetics, isoflurane, desiflurane is preferred, is a safe. Now the NSAIDs are very dangerous in case of the hepatic compromised patients. So this should not be used frequently in this particular group of patients. Acetaminophen can be used in less than 2 grams per day, But if the pain is not well controlled, then tramadol 25 mg every 8 hours is a good choice. But neuropathic pain can be used with, treated with nortriptyline, desipramine or gabapentin, pregabalin. But combination of these drugs with tramadol should not be done. So tramadol, when it is used along, it should be used individually, or the acetaminophen up to the 2 gram per day. But combination drug you should avoid with tramadol, maybe because of the to avoid the hepatic encephalopathy and opioid toxicity. So these are the drugs on the left hand side should use, are frequently used in hepatic compromised patients. You all know that is spironolactone, furosemide, ciprofloxacin for spontaneous bacterial peritonitis, rifampicin and lactulose for preventing hepatic encephalopathy, terlipressin, propranolol, carvedilol to prevent the bleeding from the esophageal varices. And these drugs are absolutely no-no, that is NSAIDs, that is AC inhibitors. AC inhibitors, in fact, they increase the chance of renal toxicity in the case of the hepatic compromised patients and ascitic patients. So the AC inhibitors should be avoided, and even if it is used, there should be dose reduction. So aminoglycosides and gentamicin should be avoided because that will increase the chance of renal failure. To prevent the development of the hepatorenal syndrome, it should be avoided. So the antidiabetics drugs, so in case of the hepatic compromised patients with a compensated, that is not in a decompensated state, you can use any of the antidiabetics, but that should be monitored very well, the dose should be adjusted. But in the decompensated patients, naturally the insulin is preferred. Insulin is preferred, other oral antidiabetics it should not be used because it will be handled in a different way. So best is the insulin. And the proton pump inhibitors are preferable than H2 blockers because you know these H2 blockers can have the hepatic dysfunction. Statins appear remarkably safe because there are several studies that is we can have this apprehension that statins might be more toxic in the hepatic compromised patients, but statins appeared remarkably safe. There are several studies within hepatic decompensated cirrhotic patients as well as versus the normal hepatic function patients. That is, there is no added derangement or disadvantage with while using these drugs. So, sometimes you need to adjust the dosage. These are the several drugs which can cause the acute hepatic toxicity in the form of hepatocellular injuries, cholestatic injury, fulminant hepatitis. That may be these drugs better to be avoided. Mostly these are the antibiotics. And the hepatorenal syndrome should also be considered when there is a presence of the concomitant renal dysfunction. You need to adjust the dosage according to the renal dysfunction as well. In the volume of distribution of the hydrophilic drugs, they are getting increased in case of the patients with ascites. So the loading dosage should be increased if you need to have a desired effect in this particular group of patients. And you need to avoid the drugs with narrow therapeutic index. That is to be remembered, particularly in the patients having severe hepatic dysfunction. So the take-home message, the prescribing medicines in hepatic compromised patients is very challenging. As you will know, there is more than 100 drugs can cause the fulminant hepatic failure, and there is actually no clear test which can guide us the drug metabolism and in this particular group of patients. And the most judicious approach is the individualization of the treatment and the monitoring the clinical and biochemical parameters regularly, and the clinical judgment along with backed up with the proper clinical pharmacological knowledge and drug interaction is the key for the successful management of this particular group of patients. So these are my references, and thank you very much.
Thank you, Dr. Bagchi. This is a very complex topic actually, and thankfully in general practice, this is, one comes across this less. It is usually severely compromised patients that are there in hospitals where you have to deal with this kind of thing. But very complex, and you've presented it very well, so thank you so much for that. Are there any questions for Dr. Bagchi? Absolutely, yeah.
Medicines are being used, and the patient also has poor ability to really accommodate all these.
Right.
So, there again, there is a huge hope for clinical pharmacology and consultation.
Right.
For proper guidance and
Right.
very well done.
Thank you, sir.
Very well done.
Thank you.
Okay, yeah. So Dr. Munshi has to leave. Can we arrange for the felicitation?